Good morning, everyone. I'm Stephanie Maselli, a media officer with the National Academies of Sciences, Engineering, and Medicine. Thank you for joining us today for a webinar for the recently released report, Social Isolation and Loneliness in Older Adults, Opportunities for the Healthcare System. The slides and recording of this webinar will be available by next week at nationalacademies.org/isolation and loneliness. There you can download the report and related resources today as well. And for those of you who are not familiar with the U.S. National Academies of Sciences, Engineering, and Medicine, we are private nonprofit institutions that provide independent, objective analysis and advice to the U.S. to solve complex problems and inform public policy decisions related to science, technology, and medicine. For each requested study, panel members are chosen for their expertise and experience, and they serve pro bono to carry out the study's statement of task. The reports that result from the study represent the consensus view of the entire committee and must undergo external peer review before they are released, as did this report. I have with me today several members of the committee to discuss the report, but before I introduce them, I want to go over a few reminders. Please note this webinar is scheduled to last 1 hour. We'll start off with a presentation summarizing the report by the committee members, and then we'll open it up to any questions you may have. To submit a question, you can simply click the Q&A button on the bottom of your screen. And if you have any technical issues during this webinar, you can contact Zoom support at 1-888-799-9666 and select option 2. And with that, I'd like to introduce the members of the committee that wrote the report who are here with us today. We have Dan Blazer, who chaired the committee. He's J.P. Gibbons Professor Emeritus of Psychiatry at Duke University School of Medicine and a Senior Fellow at the Center for Aging at Duke. We have Colleen Galambos, Professor and Helen Bader Endowed Chair in Applied Gerontology at the University of Wisconsin Milwaukee's Helen Bader School of Social Welfare. She's also an adjunct professor at the Wisconsin College of Medicine. We have Julianne Holt-Lundstad, Professor of Psychology and Neuroscience at Brigham Young University, where she also has a joint appointment in gerontology. And finally, Julianne Sebastian, Dean and Professor of the College of Nursing at the University of Nebraska Medical Center. And with that, I'd like to turn it over to Dr. Blazer to kick off the presentation.
Yes, I also want to thank everyone for being with us today. I am Dan Blazer, and I did chair the committee for the National Academies on the health and social dimensions of social isolation, loneliness that authored this study. And I'm also happy that Dr. Galambos, Dr. Holt-Lundstad, and Dr. Sebastian are with us on this call as well. We especially want to thank the AARP Foundation, which supported this study. They were tremendously helpful throughout the process and really allowed the National Academies, I think, to do its work as well as possible. If we could move on to the next slide. I want to recognize the full committee. I'm not going to read all of these names. They're going to be readily available to you. What I do want to emphasize is that they represent a wide range of expertise, which was essential in producing this report. We had many very informative discussions, and we certainly learned from one another. If we go to the next slide, please. This is a brief look at our statement of task. Again, I'm not going to read this in depth. But the first step in our statement of task is to understand the evidence for social isolation and loneliness affecting health and quality of life. I want to leave one bullet point with you on this in terms of our findings, which we'll come back to in more depth later. And that is social isolation and loneliness are clearly public health concerns that our communities and our health care profession needs to pay attention to. If we could go to the next slide. We also were asked to identify and recommend opportunities specifically for clinical care to help reduce the incidence and adverse impacts of social isolation and loneliness. Some may question whether this is a task for the healthcare profession. We want to emphasize that we feel that it definitely is. We go to the next slide, please. Some people wondered why we looked at the role of health care systems specifically in this area, and we recognize that the healthcare system is not the sole or perhaps even the primary source of resources which may help this very large problem of social isolation and loneliness. However, we often are the first responders. We're the individuals who may see, especially the vulnerable older adults who are socially isolated and lonely and experiencing health problems, because we may actually be the only contacts that they have in the healthcare profession. With this brief introduction, I want to introduce Dr. Julianne Lonstead, who will begin our discussion of the basic definitions.
Thank you. Over time, different aspects of social relationships have been studied, and these terms and many terms and measurement approaches used in these studies have led to a very complicated literature base. So I wanted to clarify how we define and use terms in our report. Social isolation is an objective lack of or limited social contact with others, while loneliness is the perception of social isolation or the subjective feeling of being lonely. These are distinctly different phenomenon. People who are lonely are not necessarily isolated, and people who are socially isolated are not necessarily lonely. Furthermore, social isolation and loneliness are also different from many other aspects of social relationships that have been studied, including social support, social networks, social exclusion, social integration, etc. Recently, the term social connection has been suggested to encompass the variety of structural, functional, and quality aspects of how individuals connect to one another. If you could advance to the next slide. The committee encountered several challenges when examining the literature related to social isolation and loneliness, including conflation of social isolation with loneliness, variability in terminology, measures and measured outcomes, limited research on low-income, underserved, and vulnerable populations, a group the committee calls at risk, limited research on interventions specific to clinical setting, and finally, the quality of the available evidence. If you could advance to the next slide. Despite these challenges, the committee found substantial evidence that social isolation and loneliness are associated with greater incidence of major psychological, cognitive, and physical morbidities and lower perceived well-being or quality of life. Some of the most compelling evidence comes from the association of social isolation with significantly increased risk of premature mortality from all causes. There is some evidence that the magnitude of the effect of social isolation on mortality risk may be comparable to or greater than other well-established risk factors, such as smoking, obesity, and physical inactivity. We could advance to the next slide. Some factors may increase a person's risk for being socially isolated or lonely, while other factors are protective. Physical risk factors include many common chronic diseases and conditions, including heart disease, stroke, cancer, functional status, and sensory impairment, particularly hearing loss. Psychological, psychiatric, and cognitive factors include major depression, generalized anxiety disorder, social anxiety disorder, and impairments related to dementia. It is important to note that depression and loneliness are not the same, and many studies find independent effects. Finally, a variety of social, cultural, and environmental factors can put an individual at risk. These include factors such as bereavement, retirement, and driving or housing status. Can we advance to the next slide? As noted earlier, Understanding the full scope and complexity of the influence of these risk factors on health is challenging. Aside from the protective and risk factors, moderators are the factors that influence the magnitude or direction of the effect of social isolation and loneliness on health. For example, in addition to the absolute number or extent of social relationships, the quality of such relationships is also important. While both social isolation and loneliness can affect health throughout the life course, aging, independent of other factors, does not cause social isolation or loneliness. Rather, older adults are at increased risk for social isolation and loneliness because they are more likely to face predisposing factors mentioned previously. Finally, a variety of mechanisms, known as mediators, have been suggested to explain how social isolation and loneliness influence health, including changes in cardiovascular, neuroendocrine, and immune functioning, inflammation, decreased quality of sleep, and physiological stress response. Next slide. The committee formulated its recommendations in accordance with 5 goals, each of which address an aspect of enhancing the role of the healthcare system in addressing the health impacts of social isolation and loneliness in older adults. The committee emphasized that the preservation of an individual's own decisions regarding his or her life is essential as a guiding principle for all interventions. These goals are: 1, develop a more robust evidence base; 2, translate current research into healthcare practices; 3, improve awareness of the health and medical impacts of social isolation and loneliness; 4, strengthening ongoing education and training; and 5, strengthen ties between the healthcare system and community-based networks and resources. I'd like to now turn to my colleague, Colleen Galambos, who will discuss the recommendations related to the first 2 goals.
I'm going to talk about the first 2 goals as Dr. Holt-Lumsden mentioned. If we could go to the next slide. The committee's first goal is to develop a more robust evidence base for effective assessment, prevention, and intervention strategies for social isolation and loneliness. To meet this goal, the committee identified 2 priority areas for research: basic science research on social isolation and loneliness, and research on effective clinical and public health interventions. Next slide, please. Social isolation and loneliness are as prevalent in today's society as many other well-established risk factors for health. Yet limited resources and attention have been paid to these issues. The committee recommends increased funding for basic research, including how social isolation and loneliness relate to and operate with each other, the risk factors, the mechanisms through which social isolation and loneliness affect health, and the factors that affect all of those relationships. This evidence is needed to inform more effective interventions. Next slide, please. The overall quality of the evidence for specific clinical and public health interventions is mixed. In part, this is due to the heterogeneity of older adults themselves and among the underlying causes of their isolation or loneliness. While there is some evidence for promising approaches, the committee concludes that researchers are only beginning to understand which specific approaches work best for which populations and which risk factors. Different intervention approaches may be needed for social isolation versus loneliness, or for the different underlying causes of an individual's isolation or loneliness. The committee identified 3 major aspects of the evidence base for effective clinical and public health interventions that need to be addressed in order to determine best practices and approaches: quality, funding, and research gaps. That is, the overall quality of the evidence base needs to be improved, adequate funding of research will be required, and research on major gaps in the current evidence base needs to be prioritized. Therefore, the committee made the following recommendations. Next slide, please. First, to improve the quality of the evidence base, the committee calls for the prioritization of research that builds a scientific foundation for effective clinical and public health interventions. In order to accomplish this, the committee recommends that the design and evaluation of any intervention should consider a number of key elements that will enhance the ability to compare across studies. In conjunction with this call for improvements in how interventions are designed, the committee recommends an increase in the overall funding of interventions specific to clinical settings. Next slide, please. Finally, to accomplish the goal of developing a more robust evidence base, the committee recommends prioritization of research on specific gaps, including tailored interventions based on a public health framework of primary, secondary, and tertiary prevention, trends among younger adults as they age, innovative funding mechanisms for interventions, approaches for understudied groups of older adults such as low-income or LGBT adults and those who face unique barriers to health, an assessment and testing of technological innovations for benefits, potential adverse consequences, and contextual issues such as having broadband access and having adequate knowledge to use the technology. Next slide, please. Our second goal is to translate current research into healthcare practices. Given the evidence for the broad-reaching impacts of social isolation and loneliness on the health of older adults and the emerging evidence for their impacts on healthcare utilization, the committee concluded that the healthcare system is well poised to develop methods for beginning to identify social isolation and loneliness in healthcare settings. By first identifying those at highest risk and potentially whether their isolation or loneliness is acute or chronic, clinicians and healthcare researchers may be able to use these findings to target appropriate interventions to individual patients, as well as to target high-need regions and populations served by a practice or healthcare system. Furthermore, this will support a stepwise approach to care that includes the identification of individuals at risk, the provision of education, and ultimately intervention. Finally, for many older adults who are socially isolated or lonely, healthcare providers may be able to identify underlying causes for the isolation and loneliness, which may be addressed through established evidence-based practices. While some people question the value of identifying individuals at risk, when in many cases specific effective interventions have not been developed, the committee recognizes that many healthcare providers and professionals are already implementing programs for social isolation and loneliness, and so program developers need to understand best practices for identifying at-risk individuals to engage in these programs. Therefore, the committee recommends that the healthcare providers and practices should periodically perform an assessment using one or more validated tools to identify older adults experiencing social isolation and loneliness. In the case of older adults who are currently or at elevated risk for social isolation or loneliness, healthcare providers should discuss the associated adverse health outcomes with these older adults and their legally appointed representatives. Providers should make appropriate efforts to connect isolated or lonely older adults with needed social care. For older adults who are currently socially isolated or lonely, healthcare providers should attempt to determine the underlying causes and use evidence-based practices tailored to appropriately address those causes, such as in the case of hearing loss or mobility limitations. A variety of established research tools can be used to measure social isolation and loneliness, each with its own strengths and weaknesses. An important aspect of selecting a tool for use in clinical settings is standardization. This means that within a specific healthcare system or organization, all clinicians should use the same tool or set of tools. They should use only validated tools and refrain from using only parts of existing tools or creating new unvalidated tools. While the committee recognizes that some variation in choice of appropriate tools may be necessary for assessing certain specific populations or health conditions, it emphasizes that the chosen measurement tool needs to match the research question. That is, if assessing for loneliness, for instance, the tool needs to be validated specifically for the measurement of loneliness as opposed to other indicators of social connection. Furthermore, more effort is needed to update existing tools and to develop and validate better tools that can fully capture the experience of social isolation and loneliness among today's older adults. The committee recommends linking clinicians and others who are implementing new interventions with formally trained researchers early on in the design of the intervention to help ensure robust research design, as well as to evaluate the application of currently available evidence-based tools to assess social isolation and loneliness in clinical settings, including testing and applications for specific populations. Finally, the committee concludes that assessment data need to be included in clear locations in the electronic health record. I'd now like to turn to my colleague, Julie Sebastian, who will discuss the recommendations related to the last three goals.
Thank you, Dr. Galambos. Let's begin with Goal 3, to improve awareness. As with other public health issues, a critical step toward preventing, mitigating, or eliminating the negative health impacts of social isolation and loneliness is to improve awareness among the general public, and for this report specifically among the healthcare workforce itself. Therefore, we recommend the inclusion of measures of social isolation and loneliness in major, large-scale health strategies and surveys, such as Healthy People and the National Health Interview Survey. Furthermore, the committee recommends the creation of public health campaigns that highlight the health impacts of social isolation and loneliness by a variety of stakeholders. Specifically, we call for organizations representing health plans and providers to include consumer-friendly information about the health impacts of social isolation and loneliness among their patient-facing resources, such as wherever they provide information about self-management of various diseases and conditions. Next slide. Goal 4, strengthen ongoing education and training. Education and training the healthcare workforce about addressing social isolation and loneliness requires a broad approach. Workforce development is needed within formal degree and postgraduate programs for health professionals, in training programs for direct care workers and community members, and in lifelong learning opportunities. While evidence is not yet available to support curricular content on specific interventions, enough is known about the health impacts to warrant broad curricular recommendations for all health professionals and all health careers in areas such as the prevalence of social isolation and loneliness in older adults, the health outcomes and risk factors of social isolation and loneliness, and how to assess for these problems. Health professionals also need to learn how to work directly with older adults and their significant others to support prevention and reduction of social isolation and loneliness, and ways to make and follow up on referrals with appropriate community-based services. This includes learning to work with direct care workers, community health care workers, family caregivers, and other community members as part of a team-based approach to helping older adults. Competency in each of these areas will become increasingly important as systems of care are developed for preventing, assessing, and treating the negative health impacts of social isolation and loneliness among older adults in clinical settings. The committee recommends that formal programs include interprofessional team-based learning experiences in these areas. As evidence on effective interventions develops, programs should also address integrating these interventions into clinical practice and as part of discharge planning, care coordination, and transitional care planning. Similarly, health professional associations should incorporate information about the health and medical impacts of social isolation and loneliness in their advocacy, practice, and education initiatives. Finally, different educational and training approaches need to be tested to determine the most effective ways to enhance and strengthen the competencies needed. Next slide. Goal 5, strengthen ties between the healthcare system and community-based networks and resources. Like other social determinants of health, social isolation and loneliness are community-wide problems, and some solutions will require coordinated approaches between the healthcare system and community-based social care providers. Therefore, the committee recommends that national, state, and local coalitions of public and private healthcare leaders, including minority-based community organizations, work collectively to create effective team-based care and promote the use of tailored community-based services. The committee points to the 2019 National Academies report entitled Integrating Social Care into the Delivery of Healthcare, which provides many examples of such collaborations, many of which are relevant for socially isolated or lonely older adults. The committee concluded also that a centralized sharing of resources and best practices would be highly beneficial. Therefore, the committee recommends that the Department of Health and Human Services establish and fund a national resource center for evidence, resources, training, and best practices on social isolation and loneliness, including older adults and diverse and at-risk populations. As a final point, I'd like to note that while our recommendations provide specific avenues for translation of new findings and communication of new information targeting healthcare practitioners, in Chapter 10, we present an overview of best practices in dissemination and implementation of scientific evidence into regular and effective use, with specific examples related to social isolation and loneliness. And now I'd like to turn this back to our chair, Dr. Dan Blazer.
Thank you, all three of you, for just excellent reviews of the report. What I would like to do in just a moment is open it up for questions, but let me just make a couple of comments. Number one, we've learned a lot about the risk for adverse health outcomes secondary to social isolation and loneliness, but we still have much to be learned, especially when we look to specific intervention approaches which may work best with certain subpopulations. We feel that assessment can help to identify underlying causes of individuals with social isolation and loneliness in order to address any medically related issues, as well as to connect individuals with needed social care. This, again, emphasizes the point we've made throughout, which is that in some ways the healthcare profession for older adults actually may be the first responders. But at the same time, we have emphasized throughout the report the essential nature of collaboration with other groups who can work in this area and who already are working in this area as well. The healthcare system may also be in the best position to consider the underlying pathology that may be resulting, which in turn towards the mechanisms Dr. Holt-Lunstead referred to. I want to again remind you that the report is free for download on the National Academy Press website. I think you have the link to that. You can also join the conversation on Twitter in NASEM_health, and on the our Facebook page, which is NASEM Health and Medicine. So if those are the ways you can get information or would like to get information, you can get it that way. Again, the report is available now by link, as mentioned before. I failed to mention initially, but I want to recognize three of our outstanding staff who really helped make and were essential in making this report possible. And that is Tracy Lustig, who was the individual who coordinated the staff response to this report. In addition, Jennifer Cohen and Kendall Logan. We want to now open it up for questions. I think we have plenty of time, and I think that what we will do is, I think you're sending your questions in written. They will be stated to me orally, and then I will either make a comment or two myself, but mostly I'll be turfing these over to our other committee members. Thank you.
Thank you, Dr. Blazer, and thank you to the committee for a great presentation. Our first question for you all is, how does your report speak to, or does it offer ideas for how the healthcare system can partner with community organizations and social service organizations?
Okay, I'm going to ask Dr. Galambos to maybe initially respond to that, and then maybe some other committee members would like to do that as well.
There are a number of ways that that we can begin to decrease what I would call the silos between healthcare organizations and social service organizations. One is to begin to develop community collaborative committees and response systems so that each can work together to address some of the problems that are of a social nature but end up being identified in the healthcare system as well. And each can partner together so that the individual is receiving adequate health care, but also the social needs are being met as well. I would also like to mention again, there was a report, a National Academy report that we referred to, integrating social care into the delivery of health care, and that's a wonderful report to go back to and look at some of their recommendations, because they give a number of recommendations that does just that.
Okay, thank you, Kaloni. Any of our other committee members like to respond?
This is Julie Sebastian, and I'll comment that we have a number of processes in place in healthcare organizations today that can be strengthened and intentionally focused on identification and reduction of social isolation and loneliness in older adults. Examples include discharge planning, care coordination, transitional care planning and transitional care programs, and activities such as these create an automatic approach for linking the healthcare organization with community-based organizations. Further, as healthcare organizations build in some outreach of their own, this also provides another opportunity for being more involved in the community and reducing these problems for older adults.
Okay. I would just conclude by stating that, and sort of following up with both our committee members' comments, that the models are already there. This is really a question of educating caregivers in the medical professions and the healthcare professions in terms of what those models are, how they might work, and providing some room for that to take place. We have another question?
Yes, the next question is, what do we know about ethnic and racial differences in the prevalence of social isolation and loneliness, and did you identify any specific at-risk populations? Well,
two populations that we definitely considered were, number one, the LGBTQ community. We think would be at a special risk for perhaps being isolated, and especially again as they age, because they may be cut off from connections which they may have had previously. We considered many other groups that potentially could be isolated. Of course, we think about the elderly being isolated. It turns out that younger persons may be isolated, and so we need to consider younger persons in this process, because even though you might have 15 sitting around together, they're all on their iPhones, and they really are not interacting with one another. Another group we considered were the underrepresented minorities within the community. We also considered individuals in rural areas. We think that for the most part, racial and ethnic differences were not great in terms of the frequency of isolation and loneliness. But nevertheless, this is an area we need to continue to look at, because there certainly are at-risk areas in the community, and those would be populations that would be prime for intervention. Other committee members like to make some comments?
This is Julianne Holt-Lundstad. Just to reiterate what Dan was saying, we did consider each of these groups, and in addition to examining the prevalence rates, we did look to see whether or not any of the health effects or the medically related consequences of social isolation and loneliness were moderated by any of these factors. And unfortunately, the literature base is not as robust, meaning that there were fewer studies that specifically examined these. And so this is an area where we have identified that there is a strong need for additional evidence and additional research.
Okay, thank you, Julianne. Next question.
Many healthcare providers already feel squeezed to see as many patients as possible due to cost pressures. How are they going to find time to identify patients who may be experiencing or at risk for social isolation and loneliness during what is already a very brief appointment?
So this is certainly something we discussed. I think one answer is that using identification tools that may trigger the fact that social isolation or loneliness or both are present would be an important step. I think this is an eternal question. Every time we come up with something that we recognize to be a significant public health problem, we're always confronted with the issue, well, the physician, the nurse, the social worker, other healthcare professionals are faced with so many complex problems that they're having to deal with. How are they going to squeeze one more thing in? I think our answer back generally is not to provide a specific menu in terms of eliminate this and add that, but rather to emphasize the importance of social isolation and loneliness in the overall health and well-being of the individuals who we're working with. And just getting this on the radar screen of our healthcare professionals, the healthcare system, I think is most important.
This is Colleen Galambos. I'd like to jump in and say that also using the interdisciplinary healthcare team to help in the assessment. So you may have a medical social worker or a clinic nurse who can step in and help provide some of the support to do the identification and the assessments.
This is Julie Sebastian. I think that's a key point. And I will add that although it's limited, the family and social histories that are part of regular clinical care provide a door opener, essentially, to determine whether or not social isolation and loneliness may be risk factors or actual problems for certain individuals. The other matter is that we found very strong associations between social isolation and loneliness and health outcomes, specifically various causes of morbidity and even correlation with all-cause mortality. And so addressing this issue is a way of also addressing other problems at the same time.
Okay, thank you. Next question.
As a follow-up to that, why should providers work to identify or assess patients for this issue when there isn't robust evidence for interventions yet?
Okay. This is also a question that we considered at some length. I think the answer that most of us came up with, I want to ask our other committee members to add in as well, is that we're concerned about the health and well-being of the individuals who we're working with. There are many areas, unfortunately, in healthcare where we don't have clear answers in terms of what the next best step is. That doesn't mean we aren't concerned about those. And we have reason to be concerned. And also, even though there may not be a general way to intervene, for example, clinicians, especially astute clinicians, may be able to identify specific issues where intervention is very possible. One that we talked about often in our committee deliberations was the fact of hearing loss. Hearing loss may isolate an individual. and yet the use of appropriate techniques to improve hearing capabilities might have a significant effect on improving the connectedness of individuals with whom we happen to be working. Let me ask the other committee members, do they have some comments also?
Yes, this is Julianne Holt-Lundstad, and as we've mentioned before, the body of evidence is strongest when it comes to the health consequences of social isolation and loneliness. And so assessing those that are risk helps healthcare professionals understand who is at greatest risk for these health consequences. And efforts can be implemented in terms of primary, secondary, and tertiary kinds of preventative efforts. Of course, just like any other healthcare concern, the evidence base is continuing to evolve and grow, and as we gain additional evidence, that these can inform these kinds of decisions.
And this is Julie Sebastian. I'll comment as well by saying that there are many areas where we're seeking additional evidence, but when clinicians are confronted with these issues, they use their best, most well-informed clinical judgment to initiate interventions. We believe, however, that in addition to that, we need much more research to help us learn how to best target interventions for specific individuals and specific populations.
Yeah, let me underline that point that Julie made, that all of us are quite aware of. We need an evidence-based background in order to develop and implement the interventions that we feel like might be effective. So intervention research is essential here. Next question.
Did you consider the experiences of patients with cognitive decline and how that might play a role in social isolation and loneliness?
Yes, that was very much a part of our report. And I think the first thing to recognize is this is a two-way street. The first direction is that social isolation and loneliness has been shown to be a risk factor for an increased rate of cognitive decline among older adults, perhaps even leading to the dementias. On the other hand, individuals who have even mild cognitive impairment would be at greater risk for withdrawing because they feel like they can't keep up with or engage in conversations, and that creates a problem. And so we very much are aware that this, unfortunately, quite prevalent and serious problem that older adults face, especially as they get over the age of 75, could certainly conflate with the issue of social isolation and loneliness, and they can certainly have an additive effect. Other our committee members like to make a comment? So maybe we can go to the next question.
Can digital health and health technology actually address social isolation and loneliness, or are they just making the issue worse?
This is something also that we discussed in some depth. I'm actually going to turn to Colleen and Julie and ask them to maybe comment on this. We had an expert on the committee who worked with us to try to understand, for example, the role of robotics. We talked a lot about the use of technologies that may be computer-based, et cetera. I'm going to let those two give us some background in terms of what those findings were. So, Colleen, perhaps you could go first.
I'd like to start out by saying that when we looked at the literature, there are some promising uses of technology in relation to robotics is one, using the internet, using social media to connect people with loved ones, older adults, also volunteers who can check in. So there's a lot that is going on in this area in relation to using technology. We have to be very careful, though, in terms of what the results say in relation to this. We need to collect more evidence. to determine exactly what the benefits are. And we need to be very cautious in terms of making sure that when we recommend technological solutions, that people have access to broadband, that people have access to computers, to the internet, that there's appropriate connectivity. And that we also have to look at the capabilities of that individual. So somebody who, we mentioned a little bit earlier about cognitive impairment, somebody who is cognitively impaired and is having a difficult time communicating, this technological advances in using internet or connecting with individuals using a granny pad, for instance, may not be the most useful resource for them. However, the use of a robot who can remind them and give them prompts in terms of how to conduct their daily activity may be exactly what it is that they need. So looking at our recommendation in terms of tailoring interventions to that person's specific needs, we really need to spend some time assessing what that individual's capabilities are and then assessing the technological advances that are out there and to select one that more appropriately is tailored to that individual's needs.
Okay. Julie?
Yes, and so I'll just comment that we did, as Dr. Colombo said, see a lot of promise in technology, a whole range of types of technology. But again, we thought there was need for more research to be able to effectively tailor the technology with the needs of the individual. But as well, we thought there were issues that we needed to evaluate more fully around privacy, around ethics, autonomy, that sort of thing. In addition to some conversation and some study that we engaged in around what's been called the digital divide. Most often, digital divide we've found was used to describe broadband access, comparing urban areas with rural areas. But in certain low-income urban areas, digital divide also is an issue. And it's an issue of access to broadband as well as access to adequate peripherals, adequate knowledge of how to use the materials, the technology, and then, as Colleen mentioned, the individual's cognitive capacity.
Okay, and I would just...
may I add also?
Yes.
This is Julianne Holt-Lundstad. We also included the importance of really understanding the effectiveness of these various technological devices, environments, and approaches, and that success needs to be measured not just in terms of uptake and usage, but in the actual effectiveness of reducing isolation and loneliness and ultimately the health implications of that, and that this effectiveness needs to be clearly evaluated, and if something is determined to be effective, that then we can consider equity in access to those benefits.
I would just make a final comment, and that comment is technology may facilitate social connections, but it does not replace person-to-person connections. Next question.
Yes, and before we dive into that, I just want to make a correction here. The report and resources are downloadable at nationalacademies.org. Again, that's .org/isolation and loneliness. I believe the slide says .edu. Next question is, how can faith-based organizations and religious organizations play a role in addressing this issue?
Well, we did not specifically address faith-based and religious organizations. I think that one comment would be many of the recommendations that we made certainly would apply to religious organizations, especially the larger organizations who have many resources available to them that we do refer to in the report. I think the other thing that I would just mention, which is basically self-evident, and that is religious organizations often have a built-in connectivity with their members that should be able to facilitate identifying individuals who may be social isolated or lonely, and they also have the resources, often through programs themselves within their congregations of one type or another, which certainly could facilitate individuals to be more connected within that community itself. Other of our committee members may have some other comments.
This is Julie Sebastian, and again, we didn't study one particular type of organization, but we absolutely recognize that faith-based organizations are critical parts of communities, and as such, healthcare organizations should consider partnering with any type of community organization that provides services to older adults and that could be part of resolving these issues.
Yes. Okay, next question.
How do you recommend measuring social isolation as a start in the work field? Is there more we can do beyond just asking simple questions to clients or patients?
I'm going to ask Julianne if she might respond to that.
Yes, thank you. That's a great question. It's critically important to use validated measures. There are several available, and we do outline these in the report. And these have not only been validated, but they're reliable. And by using consistent measures, these have been used across a number of studies that predict these kinds of health outcomes that are so critically important and relevant to the healthcare system and healthcare professionals. And so if we are trying to, whether it's assessing those who might be at risk in a clinical care setting or in other kinds of settings, by using some of these measures, it will help keep things consistent so that it can be integrated into the larger knowledge around this evidence, and that there's we also talk about the importance of another Academy report, the Institute of Medicine, that recommended that this be included in the electronic health records. And by routinely and consistently collecting this information, we can better determine to what extent this is having an effect more broadly in terms of population health as well as individual health.
Okay, I may comment. As I understood the question, I may have understood it incorrectly. One aspect of the question was how might we go beyond just questionnaires or typical assessment forms, and we did not discuss that specifically in the committee itself. Though I think that would actually be an obvious kind of next step in terms of considering how we identify individuals who are isolated or lonely. I think one point that I would emphasize here, and this especially what I think would relate to the workplace, and that is you cannot say that social isolation is the same thing as loneliness, because individuals may prefer to work alone. They may actually not be lonely at all in the workplace. They may have adequate and excellent relations outside the workplace, but their workplace self-experience may be on their own. So it's important to not put those two things together. But I think the question regarding, what else could be done in the workplace, we did not address it, but I think that's a step that could be made.
Following up on that, how important is it to make that distinction between social isolation and loneliness when we're talking about risk factors, consequences, and interventions?
Well, clearly, and I'm going to let Julianne discuss this because she's the expert, but I'll just make a brief comment, and that is clearly they're related, though they're not identical, and I think that's a point we make again and again within the report. So the risk factors for one may not be the same as the risk factors for others, and the consequences may not be the same, though I think they often tend to run together. So, Julianne, I'm going to turn it over to you.
Yes, this is a great question because these terms are often used interchangeably. And of course, we do have evidence that those who are socially isolated are at increased risk for loneliness. However, as has been mentioned before, they don't necessarily always go hand in hand. So isolation is really thought to be more that objective lack of social contact or infrequent social contact, whereas loneliness is really that subjective feeling that may or may not be associated with isolation. We do have strong evidence that both are associated with significant health outcomes, including risk for premature mortality. So there is no evidence to suggest that one is necessarily stronger than the other, although there is some evidence more recently that suggests to some extent isolation may have more evidence, but that rather we need to take both seriously, and that we don't assume that just because someone is one but not the other, that they're not at risk. So if you only assess isolation and don't assess loneliness, you can miss risk. And if you only assess loneliness and don't assess isolation, you miss risk. And if you only intervene upon one and not knowing what an individual may be at risk for, or experiencing, and as I had mentioned, and understanding those underlying causes, those interventions may be ineffective, and that we really need to make sure that our intervention approaches match the underlying needs of the individual. Okay.
Next question.
To what degree are healthcare professionals being educated about this today, and what are some future priorities for training and education?
Well, we have gone through within the report a laundry list of things that we feel like can be done. I think in terms of the degree to which health professionals are educated in this area, there's a simple answer: that's not enough. We really need healthcare professionals to have this more on their radar screen, and not only just the fact that there are people out there who are socially isolated or lonely, but also some of the risk factors, what's the quality of those relationships, etc., and what are the health outcomes that you might see from those situations. So I don't know if some of our other committees, perhaps Julianne would like, excuse me, not Julianne, but Julie would like to comment given her expertise, but our report is replete with examples.
I'll just comment by saying that we know health professionals are educated about psychosocial issues and about assessing support and behavioral health issues and access to resources. But calling out social isolation and loneliness is another thing entirely. And despite the spotty evidence on interventions and our call for more research on effective interventions, the epidemiology of social isolation and loneliness is something that we believe all health professionals should learn, and we think that the nature of this problem requires a more interprofessional, team-based approach to the learning that would include not only other health professionals, but direct care workers and community health workers and other community members as well.
Okay, thank you. We're getting near the end of our time, but I certainly can take one more question.
Yes, we have time for one more, and that is, did the committee consider the impact of major life events like retirement, a move, loss of a spouse, just as some examples?
Yes. Simple answer is yes. These are what we would consider risk factors for individuals developing social isolation and loneliness. I'm going to ask Julianne to maybe comment on that.
Yes, thank you. We did consider major life events as potential risk factors, and given that these, in some cases, something like retirement, are often predictable, this is an important point at which would be a good opportunity for intervention to occur, particularly in terms of preventative efforts. Of course, other kinds of major life events like loss of a spouse are less predictable. But when we become aware of this, these are great opportunities for us to potentially intervene.
Okay. Before we finish, I just want to thank our committee members and our staff from the National Academies who've just been excellent in coming together with this report. It's been a privilege for me to work with them. And I also specifically want to thank all of you who joined this webinar. I understand that maybe it was over 1,000 people who were out there listening. I hope we still have that number, and I hope we've engaged you enough that you will recognize the significance of this area and the opportunities that we have.
Thank you again to the committee. And as Dr. Blazer said, we did have shy of 1,000 people join today. So if we didn't get to your question, I invite you to go to www.nationalacademies.org/isolation and loneliness, and there you'll be able to download the report. You'll be redirected there once you exit the webinar. Thank you again for joining us today.